You're listening to Case by Case, the podcast where medicine meets real-world practice, one clinical case at a time. Brought to you by a continuing education company, this series brings you front-row access to compelling case studies recorded live at top-tier CME conferences across the country. Each episode, we dive into a single, real-life medical case presented and discussed by leading experts in the field. It's medical education elevated, engaging, and deeply relevant to today's practice. This is Case by Case. Let's begin.
All right, so we're going to start with the pretty bread and butter diabetes case. But as we know, the older adult is at really the highest risk of these complications, and we tend to struggle with knowing how to prioritize. All right, how to prioritize therapy. So here's an 83-year-old woman presenting with her daughter, routine follow-up. She's had diabetes type 2 for 25 years, not well controlled, A1C 8.9. She has daily pain due to severe OA, and she had a hip replacement is being recommended, but she was informed that her diabetes would need to be better controlled to undergo surgery. She's been taking degludec insulin for 42 units once nightly, plus semaglutide, 0.5 for 6 months. Her weekly for 6 months. Her BMI is 36. She's happy to have lost 8 pounds over the last year. Recently, she's had more difficulty with memory and now lives with her daughter due to safety concerns. So she is using a CGM, which is nice, and she's able to show you the summary on her phone. This is her CGM summary of the last 2 weeks. So the average glucose 210, and you can see this right in our little report. Her percent of time spent above 250, 16%. High is 24%, and that 180 to 250. Time in target range is 54%. Time below is 5% in the 55 to 70 range, and 1% of the time she's below 55. All right, let's take a look at those numbers. So which of the following is the most appropriate next step based on the CGM data? Increase semaglutide to 1 milligram weekly, increase degludec insulin by 20%, measure the A1C, and perform some iron studies suspicious of the A1C, recommend no change or decrease the degludec insulin by 20%. Aha, okay. So this gets to the heart of the issue. You know, we really want to do guideline-directed therapy for all of our patients, and our older adults who become more complex and insulin deficient, they have their own struggle. So it looks like it's between going up on the semaglutide because this patient is obese, she's poorly controlled, or decreasing her degludec insulin by 20%. So the right answer was actually decreasing the insulin, and let me explain why. So one of the issues that we saw, first of all, that cognitive impairment does put her at risk of hypoglycemia, and that should say time spent below 55, not 70, because that's actually not what we wanted, but time booked spent below 70. Yeah, that's fine. That's actually the low on the time and range, yeah. So cognitive impairment and hypoglycemia increases the risk of hypoglycemia. So for many older adults, the recommended time and range is 50% or more, and she's actually there. The problem is that she's spending much more, she's spending 5% of her time below 70, and the goal is less than 1% in people who are older. So that's the first priority. So she has osteoporosis too, and a fall would actually impair her life significantly. So once hypoglycemia is addressed, then you can go up on the semaglutide. She's on the low dose for 6 months. That might indicate she's hard to engage because that's a really low dose. Typically, we would be working with folks to go up in their semaglutide, down on the insulin. Cognitive impairment is a barrier. She has to have her son come and bring her into the office. So you can already tell that things have been moving slow. So I think we need to be careful with her. The other point is that her A1C is elevated, but it matches her average blood sugar. So the A1C is accurate. And usually, when we see hypoglycemia, there's hyperglycemia happening as a result, right? It's eating the ice cream because the sugar's low. So fixing hypoglycemia first is our strategy for all patients who take insulin. So that's great. I'm just going to actually go through this a little bit with some imagery So this is what some people show you on their phone. That 50% time in range is what we're looking for the older adult. Higher is great if they don't have hypoglycemia. But she was at 5% for that low range. Okay, great. You can also see on the CGM output this GMI, which is it's a little checkpoint to see if the A1C is lining up with what the average blood sugar is. Sometimes in older adults especially, and those with anemia, you actually see a real discordance, and it can misdirect you. You can end up over treating or under treating depending on the direction of the error. So CGM is useful for that. Keep in mind that we talked about this, that GLP-1s are really advantageous as far as adding to insulin therapy to reduce weight, insulin requirement, and A1C. And this was shown with exenatide a long time ago, but of course we have updated data with semaglutide as well. The point here is that you can do this in older adults. Don't be afraid of using GLP-1s in older adults. We do expect weight loss in older adults, but any degree of weight loss will result in some lean body mass reduction, and that's physiologic. I do like to have my older adults exercise when they're taking GLP-1s. And I'll just mention this little study that was done, the retrospective analysis, but it looked at 156 middle-aged adults. It included some older adults, and it just showed that adding GLP-1 therapy to those who were already taking insulin, 81% of those people discontinued the mealtime insulin, which isn't consistent with my practice, but almost half stopped insulin entirely. So it's important to consider.
Wow. Thanks for watching. If you found this discussion valuable, be sure to subscribe, and hit the bell so you never miss a new episode. To explore upcoming CME conferences and earn credits while staying at the forefront of medicine, visit cmemeeting.org. Until next time, keep learning, case by case.